This 18-year-old patient was referred to me for endodontic retreatment of tooth number 14. According to the patient, this root canal was done a year ago by his previous dentist. So take a look here. Huge periapical lucency. All right. But look, the dentist also ordered a Cbct. Why? Why? Why do you need a Cbct for this tooth? Why do you need a Cbct? I can already see, you could probably see, I can see, anybody can see the periapical lucency already. Why order a Cbct? There was also a buccal sinus tract. That's the tooth here. This patient was referred to me for teeth number 19 and 20. According to the patient, these root canals were done about 3 years ago by her previous dentist. A few months ago, she noticed that when she tried to chew on the left side, she couldn't. So she went and saw the same dentist, or that unfortunately that dentist passed away. The new dentist who had taken over that office, and patient claims that the new dentist told her he couldn't see anything. Everything was fine. So patient knew that everything wasn't fine. So she went and saw another dentist, and patient says as soon as the other dentist took x-rays, the new dentist told me your teeth were abscessed, were infected, and then she was referred to us. So number 19 and 20, both tender to percussion and palpation. Probings were 2 to 3 millimeters all around. You can see previous root canal, prefab metal post there, periapical lucency here, here, and here. Okay. Do I need a Cbct? Why do I need a Cbct? I don't need a Cbct. Who needs a Cbct? Take another angulation PA. Take a look. Look at this angulation. So they missed a distal canal right there. That's a missed canal. And of course, you can see the infection already. What's the reason for a Cbct? I don't get it. What's the reason for a Cbct? There's no reason. You can see on the x-ray what's going on. The tooth is abscessed, number 20, number 19, both are abscessed. And there's a missed canal right there in the distal. We go in, remove the post here, remove the buildup here, remove the gutta-percha here, open everything up, look at everything under a surgical operating microscope, look for missed canals, irrigate copiously with 6% sodium hypochlorite, sonic, ultrasonic activation, and 3-dimensional obturation. There it is. What else is there? Why is there a need for a Cbct? I don't get it. Anyways, wanted to get a Cbct, go ahead and get a Cbct, but there's no reason for it. And for those who don't have Cbcts and think Cbcts are a must, no, they aren't. So don't feel bad if you don't have a Cbct or you don't have access to a Cbct. Multiple angulation PAs will do. This patient was referred to me for tooth number 20. Tooth is part of a bridge. The bridge is about 5 years old, according to the patient. Patient says a year or so ago, tooth started to hurt, and then he went and saw his dentist, and his dentist told him everything seemed to be fine. It's probably food getting trapped underneath the bridge, so recommended flossing under the bridge. And patient says then the pain went away, but recently tooth started to bother him again. We went and saw his dentist and then was referred to us. And you can see here, there's a periapical lucency associated with the tooth. There was a small buccal swelling as well. But I want you to pay attention to this. That's why you need to be able to read x-rays and pay attention to the details. Dentistry, specifically endo, is details oriented. You have to have the eye for it. You have to have the eye for it. Take a look here. What is that? By the way, this is nothing, all right? Tooth probe 2 to 3 millimeters all around. But look at this here. What is that? Put it in the comments. This patient was referred to me for apicoectomy of tooth number 5. Very likely this dentist doesn't follow me, thinking that I would go straight to apico on a case like this. This root canal was done 5 years ago, according to the patient, by her previous dentist. A few weeks ago, she noticed a swelling above the tooth and went and saw her dentist, and her dentist told her the tooth was abscessed. So you can see there's a crown, prefab metal post, root canal, huge periapical lucency here. All right. So why go to apico when I can just go through the crown here, remove the post, remove the gutta percha, and redo the root canal non-surgically first to get rid of all the bacteria throughout the entire length of the root canal systems. Then follow the tooth for a few months. If we see that the non-surgical endodontic retreatment was unsuccessful, then perhaps we can consider apico. All right, so I may or may not put MTA there. Maybe I will put MTA there, just in anticipation, just in case if we need to do apico in the future. But we want to address the entire length of the root canal systems here. Apico doesn't. If I go and do an apico, I cut the apical few millimeters and then retrofill a few millimeters with MTA, but I left microorganisms in the untouched part of the canals. Then everything over time will leak. Then my apical will fail. So let's do non-surgical first. This patient was referred to me for endodontic retreatment of tooth number 5. According to the patient, the root canal was done 5 to 10 years ago. Recently, he noticed some pain when he touched his face in an area that corresponded to the apical area of tooth number 5. He went and saw his dentist, and his dentist told him his tooth was abscessed and referred him to us. So that's the tooth, of course. Here there's a crown on the tooth. You can see previous root canal, periapical lucency, and take a look here. Also so that's the tooth right there. And you can see a sinus tract right on the buccal of the tooth. All right. There it is. So as always, probings 2 to 3 millimeters all around. I went over patient's options with him. I never force a patient to do anything. My job as their doctor is to tell them what's going on, tell them what the problem is, what's going on, okay? You educate them, and then go over their options with them. I never push them one way or the other. I never make decisions for them. So in this case, as always, I say, sir, you have 2 options. One option is that we try to see if we can save the tooth for you. No promise or guarantees. We'll do our best. Only time will tell. I'm going to have to go through your crown here. You may need a new crown. Remove all of this material and do what we need to do, irrigate and try to disinfect the canal or canals and fill the canal again, temporize the tooth. Your dentist will take care of the rest. But I can't promise you, I cannot guarantee, I cannot give you a 100% success rate. I can't tell you that we'll redo this root canal, your infection will go away. Okay? The chances are stacked in your favor, but the chances, it's not 100%. So that brings us to option number 2. You can choose to have the tooth extracted. Okay, then you extract the tooth, the infection is gone, then you can talk to your dentist about maybe getting a dental implant, maybe a bridge or what have you. You can discuss the rest the rest with your dentist, with your general dentist. Then I say, you have any questions for me? And if they have questions for me, I respond to their questions, and I leave it to that. I let them decide. Sometimes they say, what do you think? I say, what I think is irrelevant. I can go over your options one more time, and then you can decide what you want to do. Or if you need time, take some time. Or if you need to talk to your dentist, you can talk to your dentist. So in this case, patient said, as soon as I went over two options, and I usually go over the options 2 or 3 times just to make sure that they understand. So the patient said, if you can't guarantee that you'll redo this root canal for me, my infection will go away, I'd rather just extract the tooth. And I said, fine. I said, excellent. I'm going to write a report to your dentist. What I'd like for you to do, please, is go ahead and contact your dentist today and make sure that they schedule you to have this tooth extracted as soon as possible. And patient agreed. I wrote a report to the dentist, and that's it. I didn't try to sit patient down and persuade the patient and convince the patient to try to save this tooth. No, that's not my job. My job is to tell them what's going on, and then educate them, and then go over their options. Let them decide what's best for them. This patient was referred to me for examination of tooth number 12. According to the patient, the root canal was done 8 to 9 years ago. Okay. So patient says she has had no issues, no problems whatsoever with this tooth for the past 8-9 years after the root canal was done. No issues, nothing. No pain, no symptoms, nothing. No swelling, no redness, no sinus tract, nothing. So the dentist saw this on the x-ray and wanted us to check and see what's going on. So you can see there's a crown on the tooth, percussion, palpation all within normal limits, probings 1 to 2 millimeters all around, and as you can see there's previous root canal, and there's looks like a periapical lucency there. So just because I'm an endodontist doesn't mean I'll redo this root canal right away just because I see this. So I asked the patient, I said, can we get x-rays from your previous dentist? She said she just started going to this dentist. This dentist is new. So I said, can we get the information to the dentist before this dentist so we can get x-rays from them? And she said yes. So she provided us the names of a couple of offices that she'd been going to before, and we're just going to contact them and get x-rays of this tooth from as far back as possible, and then compare them to our x-rays from today. If this periapical lucency wasn't there, now it's there, then we'll redo the root canal. If the periapical lucency was there and has remained the same size, we don't have to redo the root canal. If the periapical lucency was much larger, smaller now, we don't have to redo the root canal. We only will redo the root canal if the periapical lucency wasn't there and now it's there, or was smaller and now it's larger.